Hello, everybody, and welcome. Today's session that you're joining is family planning. I'm Andrea Friedman, Client Services Manager for the Foundation, and I am delighted to introduce you to Gretchen McCarrick. Gretchen is a senior genetic counselor in the McCusick-Nathans Department of Genetic Medicine at Johns Hopkins University. She has more than 20 years experience working in aortopathy disease. Her cardiovascular connective tissue clinic is passionate about translating results of clinical and laboratory research back to patient care and coordinating multidisciplinary expert care in these conditions. She has extensive experience with mental health and other support topics for the aortic disease population through her involvement in an advisory capacity for the Marfan and Loeys-Dietz syndrome foundations. Our other planned speaker, Jennifer Reyes, is unable to join us today, but Gretchen will cover her portion of the presentation. If you have any questions for Gretchen during the presentation, please use the Q&A option at the bottom of your screen or put your questions in the chat and we'll get to them at the end. Thank you for joining us, and I'll let Gretchen take it away.
Thanks, Andrea. Thank you, everyone out there. I'm going to try to get these slides shared in the right format. There we go. There we go. It's such an honor to be here. This is one of my favorite things every year that I look forward to, either in person or virtual. And so I really want to give you some background and information on family planning, but also look forward to plenty of time for any discussions or questions that you have. So Andrea said, I am a genetic counselor. I've worked in the Hopkins Clinic for about 20 years. Our clinic, we begin the process of talking to patients about family planning when it actually comes to the procedures and things. We usually send people to prenatal, so there might be a little gap of education about those logistics, but we certainly see hundreds of women and have had many, many conversations and involved in kind of discussions about family planning. So we are going to talk about pregnancy testing options or not. Of course, everything that we talk about, could be utilized or could not be utilized in pregnancy. It is a very, very personal decision. And I think that's the big takeaway, is that there's no one answer for every family. We're going to talk about some assisted reproduction technologies and just leave you with some questions and thoughts to think about as you might be kind of beginning through this process or thinking about this process or helping a loved one through the process. So, of course, a pregnancy in Marfan, VEDS, Loeys-Dietz, there's going to be many, many considerations even outside of your genetic and health status. And I think it's also important that, sometimes we get so focused on, what are you going to do about medical management and yes or no and recurrence risks, but also just as humans, right? We have to think about the other circumstances in our lives that might even be, more important than your genetic status. So I always encourage people also to just think logistically about finances, about life timing and what is your age and are people in school or going to be transitioning jobs, things like making sure you have appropriate housing and where are you going to live and move and have to send the kid to school, kind of what is the existing family structure, kind of what are your worldviews about having kids and what kind of support systems do you have in place. All of these are just questions that every single person needs to ask themselves when thinking about family planning, and that's the same circumstance for someone who has a vascular connective tissue disorder. I think also, some of our patients have a lot of pain or fatigue, and I think that also needs to be taken into account. That's not like an urgent vascular need that could impact the health and risk of a pregnancy or the postpartum period. But having a child just is more taxing. Breastfeeding and running after a 2-year-old is more taxing. And I think that's something that also just needs to be addressed because if people are having limitations just at their baseline, adding a 2-year-old running around is more complications to that, more challenging. So I also wanted to spend a little bit of time just thinking about where genetics might touch you or a partner or your family member outside of the specific vascular connective tissue disorder. So, there's a few other places where a geneticist, a genetic counselor might be involved talking about genetics in pregnancies. So one is carrier screening. So the conditions that we're talking about are vascular conditions, right? Are what's called autosomal dominant. So one gene from mom, one gene from dad, a gene change in one causes the condition to occur. But there are many conditions that are called autosomal recessive. So in the two copies of the genes, one from mom, one from dad, if both of them are not working, the child could be at risk of having a really severe, usually intellectually disability kind of syndrome. They could have a lot of health concerns. And so all of us are walking around and are carriers, so having one gene change for these recessive conditions. And so often now when a couple is going to get pregnant, the female will first be offered carrier screening. So what are those recessive conditions that she carries one gene change for? So she doesn't have the condition, but if her partner is a carrier of a gene change in that same gene, the kid could get both of them. So usually now any couple is offered carrier screening before getting pregnant to see if their carrier status is in the same genes. Of course, there might be age-related testing, so we know that the risk of some chromosome disorders like Down syndrome kind of increase with maternal age. There are other kind of new gene conditions that are associated with paternal age. And so all of these, in addition to the vascular connective tissue disorder, will be discussed, thinking about risk related to the age of you when you're having your pregnancy. There could be other unrelated family history conditions. So as you're meeting with a geneticist, your spouse might have a family history of cancer or of neurological disease or of muscle disease that could be running in the family outside of the Marfan-Veds-Loeys-Dietz diagnosis. And so there might actually be other genetic considerations. There is newer testing, I guess not super new, but a few years, where we can look for risks of things like Down syndrome, other chromosome disorders, or imbalances of chromosomes. And you can do this through a blood test in the mom, because there's fetal cells circulating in mom's blood cells. So a blood test in mom, kind of about 14, 15 weeks, I guess, or so, can look for a few different chromosome disorders through a blood test, not an invasive test looking at the pregnancy itself. And then sometimes, well, often, women are getting very ultrasound, very 3D ultrasounds or very detailed ultrasounds. It's done probably about 20 weeks, where they're looking for birth defects, things like club foot, hand or foot deformities, kind of structural defects that then might guide to other genetic testing in a pregnancy. So those are some other big, broad ways that genetics might touch someone, regardless of the vascular diagnosis. So when it comes to people making decisions about having a pregnancy, about family planning, there are a lot of different considerations that should be discussed. So one is the desire to have a quote unquote healthy child. So again, 50% risk for most of these are hereditary thoracic aortic diseases, but there are other risks as well. Again, thinking about family history, but every pregnancy, regardless of background, has about a 3% risk of spontaneous birth defects, intellectual disability, things that may or may not be seen on ultrasound. And so, we wish and we hope for healthy babies and pregnancies, but we do know that there is a baseline underlying risk of about 3% of birth defects or intellectual disability in a child. Also, I think a family's decision about having children or not can be really impacted by their lived experience. And this is not only their personal experience, but also their family history. I think it can also very much be system dependent. So if someone has, how do they view having a child with this condition if they have never had aortic surgery, or if their parent had an aortic dissection, or if they've had really complicated eye disease and it really complicated, their teenage years getting through school and learning and needing special help for vision aids. So all of those kind of lived experiences are going to be very personal to a person, to a family, and that clearly impacts decision making. What also impacts decision making is thinking about both pregnancy and postpartum risks. So we do think that there is a mildly, slightly increased risk of aortic dissection that can happen in a pregnancy or the postpartum period. Some of that risk is dependent upon what the aortic root diameter is. There are new guidelines that say that the risk of a type A dissection is quite small, like in the less than 10, less than 5% range. If that aorta is less than 4.5 centimeters, anything above 4.5 centimeters would be higher risk for that thoracic aorta. But we do know that what is called type B dissections, or dissections that happen kind of in that going down part of the candy cane of your aorta, those type B dissections can happen without warning, without aneurysm acknowledgement beforehand. And women can also be at risk of that. And there's no imaging markers for that. So for women who've already had their root replacement, there is still a risk of a dissection or tear happening in that descending aorta. And, that's not zero. It's really hard to kind of identify a specific number. It is not like 90%, probably closer to the like 5% range, but that risk is still there. And so that's a big decision making. And for some people, a 2 to 5% number is very low, but for other people, anything above a 0% is high. And so it's kind of that perception. And again, that lived experience. If I'm telling you that the risk is low, but your mom had an aortic dissection or your aunt had a aortic dissection after pregnancy, like that's also going to skew that kind of perception of numbers in people's brain. There is also variable expression of conditions. So in general, we think that a condition is maybe not going to go to the like most severe end of the spectrum, but there can be variability. It could be that a parent never needed spine surgery for scoliosis, but maybe a child will need scoliosis surgery, or an adult had aortic surgery at 15 and maybe the child doesn't need aortic surgery until 30 or 40. So even though there can be some range of variability, it doesn't often switch from like the most mildest to the most severe, but there can be this range of things that can occur. And then I think disease perception varies over time and even between pregnancies. So, people might be very set in one way or one decision at one time point in their life, or really think at 25, this is a decision I make. And then through life experience and aging, that might shift and change over time. I also think that there is personal values that come into play when thinking about decision making. So many individuals, especially if they have a family history, might feel a responsibility to prevent the disorder from passing on to future generations. Also, if we're thinking, and we'll be talking about some of these reproductive technologies, that, they may have questions or personal ethic or moral dilemmas when it comes to thinking about a termination of a possible fetus. Or if you're going through an IVF procedure and creating embryos, like, what do you do with those embryos when you are finished with your family planning? And so those are all questions that are deeply, deeply personal, might be impacted by familial components, might be impacted by faith and religion. And so those are just things to also consider. Clearly, there are financial considerations in having a child for everyone, but also if the child could have a special needs condition and it may have increased medical bills associated with that, how do those financial decision making and planning impact the decision making about a pregnancy? I think it's always really important to get comprehensive, balanced, and timely information. The technologies that existed a generation before are very different now, and the technologies that will exist 10 years from now might be very different from what is available today. So especially for individuals who may have physicians like on the older time frame, making sure that they are getting the most updated information about what is technically feasible these days. And I think I love the statement in the overall agenda that was like making sure that you support yourself and that you are in a good mental health place. And I think like that's our desire for anyone with one of our conditions, but especially if you're wrestling through having a family, kind of thoughts about the future planning, that can be really emotional, can be really stressful. There can be a lot of like input from other people and family members and stress and kind of anxiety and grief about like what you thought your life was going to look like in terms of family planning and kind of what is the reality of your life. So what would I say is just like really have grace with yourself and with those around you. You know, it is kind of a logical decision and very much getting all the information, but it also is this like interplay of emotions on top of that. So just be patient and graceful with yourselves and your spouses or your partners as well. So some of the technologies we're going to talk about require that you know your genetic variant. So most often, and probably like 95 to 90% of cases of aortopathy disease from our FANVEDS and Loeys Dietz, we're able to find that specific gene variant that causes that in the parent, the husband or the wife or the spouse or that generation. You must have that information to allow these technologies to be available to you. So if you were tested years and years ago and no one can find that report or what that specific variant is, you know, talk to your geneticist or your cardiologist about getting the testing and just getting that piece of paper that has it updated, has a specific variant. It is necessary. So when we think about family planning, what could that look like? What are the options? So, you know, one of the options is not having children, right? Like individuals now have really fulfilling lives, being very cool aunts or uncles or fur parents. And I think there's maybe less stigma attached these days to being child free, but perfectly reasonable option to go out and explore life without having a child. There is opportunities to just naturally have a child and then do testing after birth and just going forward and getting pregnant and moving forward in a joyful way and testing after birth. There are clearly ways to adopt. You know, unfortunately, at least in the US, it can be time consuming, it can be expensive, but you know, some people really want to be a parent but don't feel as strongly that they need to be a biological parent and have that experience of being pregnant or passing on their sperm. So clearly adoption is an option. We'll talk a little bit about some surrogacy studies that were just done where you can have a third person carry the pregnancy, and it can either be your genetic material or donated material, IVF or no IVF, but having removed that health and dissection risk from an affected mother. So not necessary if the father is affected, but if the mother is affected, having a third party carry the pregnancy. You know, using donor egg or sperm, depending upon who is affected. Then there's testing technologies we'll talk about that allow us to test when a woman is already pregnant. So being able to determine during a pregnancy if the child is affected or not. And some people would use this just for like emotional preparation to, you know, get health concerns in line and have a team after birth plan and just be prepared. And some people might choose to terminate a pregnancy depending upon where you live, if that's legal. So all those are considerations too in these technologies. And then something that people are really interested in, we probably get the most questions about, are pre-implantation genetic testing, kind of going through the IVF process. So we'll talk a little bit about that. You know, so when we're talking about invasive testing, so a woman is pregnant already, what are the options for testing a pregnancy to determine if the pregnancy has the gene variant? So the first test is something called CVS or chorionic villus sampling. And this can either be done through insertion of a catheter kind of grabs chorionic villus. These are like placental cells. So cells that are going to form the baby. So you're not necessarily taking cells that have fallen off the baby or are the baby cells, but are cells that the baby from the same origin that the baby is being formed from. And it can be either done through the abdomen or through the cervix. And so again, you're taking kind of placental cells, you're testing those to see if they have the gene variant. This is done earlier in pregnancy, usually around like 10 to 12 weeks. So it's done at mostly all major academic centers. and usually done then and getting the results in a time frame where people may not recognize or know, or you have not shared that you're pregnant. So if you test earlier and termination may be an option or on the table for you, this would be an earlier way to get those results for someone who's already pregnant. Similarly, there's a technology called amniocentesis. This is ultrasound guided. It's done at about like 16 to kind of 18, 19 weeks of pregnancy. And this is where a needle is inserted into the amniotic sac around the baby. And the baby has sloughed off skin cells. So by removing some of the fluid, you get these skin cells from the baby that are floating around in there. And then you're able to test to see if those skin cells carry that DNA variant. And again, this is done a little bit later in pregnancy. So if you're looking at a week or two for turnaround for those testing results, you might not get the results until 20, 21 weeks. So in some states, again, that's kind of pushing you up to guidelines. So it's really important to know kind of those guidelines for possible termination. But again, many people use these technologies just to know and wouldn't act on it, which is personal decision, excellent decision, but this is just a little bit later in pregnancy to determine. So you might be visibly pregnant, so people might already be aware if you're pregnant. So, we get this question a lot about like fetal anatomy scans, or even the next slide is like fetal echocardiograms. So the anatomy scan is something that, again, routinely women get. It's looking really carefully at the spine, at the extremities, at the face. Are there any large birth defects? And then a fetal echocardiogram is actually just like you get postnatally. They can do ultrasounds of the baby. Sometimes variably you can see some aortic dilation. I would say it's not great for aortic dilation. It's really good for like more intense birth defects. And so there are kind of generalized guidelines of what a normal aorta should be in fetal anatomy. But I would say if it's normal, a fetal echo, it wouldn't be 100% reassuring that the baby didn't have Marfan syndrome or Loeys-Dietz, because oftentimes that presents in the first few years of life or later. So I wouldn't be 100% reassured by that. The ultrasound, though, for things like Loeys-Dietz or vascular EDS, they might have an increased risk of club foot or other kind of contractures. And so you might pick those things up. But this is more of a big picture thing and less diagnostic specifically for vascular connective tissue disorders. So the big question that many people want to know about is called pre-implantation genetic testing. And this is for like Mendelian or molecular genetic testing. So you can do this also looking at chromosomes or other testing. This a few years ago just went through a name transition. It used to be called PGD. And so in this technology, you have the woman is going through egg retrieval, and so is having to go through the IVF process. And she'll have to do the shots of the hormones and, kind of get her cycle regulated to be able to harvest eggs from the mom. And then the father of the pregnancy would do a sperm donation. And so in a lab, you would get, put the egg and the sperm together and get a 1-cell, 2-cell, 4-cell, 8-cell embryos. And say like you get about 8 embryos that are created then. The lab is going to look at them just to determine their health and their growth. So sometimes you get embryos that unrelated to your vascular connective tissue disorder, like just look unhealthy, they're not growing well, they don't think they would be sustainable. So that might knock out like 2 or 3 of those embryos. And then they're going to remove 1 cell of the embryo, and you're not removing like an arm or a leg or anything. The cells just continue to replicate. And you're able to test that cell for that specific gene variant that the mother or father carries. And so, say you're down to 6 embryos now, and say 4 of them have the Marfan Loeys-Dietz variant. Maybe you're just down to 2 embryos now. And so then it comes into the embryo transfer. And this is also a little like interesting / controversial. of, depending upon if the mother or the father is the person who has the genetic condition. You know, if the father is infected, do you try to put both embryos in at one time, so you could have multiple gestations? Usually, if the mother is affected, I think they would only really try to implant one at a time, not wanting to get a multiple gestation in a mother who would be at risk of having a dissection in the pregnancy. But those are all things that need to be taken under consideration. As well, you know, getting the embryos created healthy, getting enough to implant, sometimes that takes more than one cycle. So it can be an elongated process, and you're not guaranteed a pregnancy after an embryo transfer, after like one embryo transfer. But this is the way then that you could pursue a pregnancy without having the vascular connective tissue disorder. What I would say is one tip or trick or thing that we've learned is that sometimes private IVF companies are a little hesitant about getting a woman with the vascular condition pregnant, whether it be naturally or through IVF, through PGT. And so sometimes if you want to go through this procedure, if the mother is affected, we would say it's worthwhile talking to your most local large academic center that follows high-risk women to access this technology if the mom is affected. You know, so I guess I would also say is that it sounds so wonderful, and of course we can do it, but there are barriers. There are just barriers of access, clearly. But also there can be it can be emotionally and psychologically taxing. So this was a quote from a woman who, we'll talk about this study, I think in the next slide, that said that the experience was emotionally and cognitively taxing, added strain to relationships, and created logistical and financial burdens. So again, it kind of reflects back on this whole like holistic decision-making process, is that even though the technology is available, it can be hard to access, but there are, you know, emotional positives and negatives to any type of family planning that people decide to pursue. You know, so clearly, you know, we've walked through this step of decision making. So identifying the at-risk, you know, status, having that variant, contemplating, considering all the decision making processes, you know, deciding to pursue a technology, and then actually taking steps in the process. You know, this is usually not like a 1 month, a 2 month, a few weeks process. This can be years to figure out. And so again, it's worthwhile for you and your partners to be thinking about family planning even early on, because it can be time consuming to kind of wrestle through all of these things. So give yourself time thinking about having this child. So this was a study that came out that was done last year, and it did some focus groups and some interviews on patients who had done pre-implantation genetic diagnosis. And so some of their themes that came out of these focus interviews was that the decision making kind of centered around their own lived experience and the severity or their perceived severity of their disease, that they really felt that there was a need for comprehensive, balanced, and timely information, and that there was also certainly significant impact of their personal values and circumstances. And so many of them described this as the only reproductive option that might be available to them. And that many patients expressed that there were gaps in the understanding of what PGT was, and that they didn't get a lot of counseling regarding the cost and the insurance coverage and just kind of the whole experience of what it's like to go through IVF. So kind of a place where we can make strides in our education about kind of not just presenting what this technology is, but maybe as genetics professionals kind of being better educators about the whole process and what it's like and the barriers and the timeframes, etc. And that finally the participants recognized that the decision was required great introspection and evaluation of one's values, but that like most things, cost remained a significant consideration. I think it's more and more being covered by insurance companies. And so when you're, at your yearly benefits plan, making sure that you're checking what are their family benefits, coverage, etc. But again, even with the PGT or the IVF, it can take many, many cycles to get embryos that are safe and healthy and get them implanted. So, there can be barriers in terms of insurance coverage on maybe how many cycles they would cover, etc. So we had two lovely genetic counseling students from the Sarah Lawrence program who kind of did a similar type study this year, interviewing couples who had done surrogacy or who had seriously considered surrogacy. And so the themes were very similar in our study. Some of the takeaways or kind of advice that we got from that was to start talking about what a family looks like very early on. And so in even the teenage years, beginning to discuss technologies, what it means to be a family, kind of risks and research that is evolved in pregnancy, really engaging at least our females in these conversations very early on. And also just bringing up these topics of like not just saying PGT is an option, but like contextualizing it. Like, what does PGT, what could that look like in terms of you feeling like you want control, but you kind of lack control in this process because another person is carrying that pregnancy and is kind of, you're giving up that control of the health and the body of that person to another person, and how will that impact you? Kind of again thinking about timing. If this is a multi-year process and decision-making process, the earlier you can start thinking, so it gives families time to start planning kind of and wrestling with their decisions, the better. Again, we as providers need to be a little bit better about educating about the finances and the logistics of it. And also just, some interesting themes that were brought up about ethics and people's views of paying another person to carry a pregnancy, and kind of how that felt, how that, were you taking advantage of them depending upon their social circumstances, etc. So there was a lot of kind of confliction over that. One of the other big takeaways from our cohort was that it took a lot of research, and many of them had to go to individual kind of centers or online companies that kind of facilitated this to get the information they felt they needed on different laws and finances and how this works, etc. And I would say that every state is different and that every country is different. And so, sometimes there are countries where only do surrogacy for like philanthropic reasons and you can't pay the woman, you just have to pay their medical bills. Other people, other states, other countries, there's a fee that you pay the woman, so she is financially benefiting from this situation, etc. So unfortunately, there's not like a national system in the United States, national legal financial system. It can be very state by state dependent. When I last looked at it, there were variable reports of like the whole surrogacy process, plus or minus the PGT options, could range from anywhere between like 100, but upwards of to around almost $200,000. So again, a lot of things to consider when thinking about family planning. So from my perspective, as someone who kind of begins the conversation with families and sees, patients in clinic, was that we start talking about family very early and very young. And, even, in childhood, when people are talking and having their baby dolls in clinic and just talking, like, families look very different. And, sometimes it is being a mom or a dad, but sometimes it's being an aunt or an uncle, or, being very close to your family members or having fur babies or things like that. So just really opening up the door that families can look different. Talking about birth control. So we don't want to get into a whoops pregnancy situation. And so just making sure that we're honest with both our teens, girls and boys, about using birth control, about using condoms, etc., to try to avoid a whoops pregnancy. We always think it's important to review medications. So some medications that people are commonly on, like the angiotensin receptor blockers for their medication management, are contraindicated, and some other pain medications or other medications they might be on just might need to be down titrated or switched to a different medication in a pregnancy. The whole goal is to really develop a team and have it kind of work around the patient regardless of their decision to get them through if they decide to do a pregnancy in a very safe, effective way. And that can mean some alteration of medications. So I also kind of think about risks, right? Like, so people want to know, like, what's the risk? Is it 5%? Is it 10%? Is it 20%? And while I really appreciate that, risks are kind of abstract numbers for people, and people view high versus low versus very low, very different. But if an event happens, it's either zero or it happens, right? And so I kind of feel like people need to be in that mindset of like, it could or it could not happen. And hopefully it won't happen, but if it happens, it happens. It's 100% happening. And like, I have to be okay with that. So again, preparation is key. I really feel it's imperative to get on the same page as your partner. And sometimes this requires couples therapy, unfortunately, having the conversation of what would it look like? How would it feel like? Is there a support system if unfortunately someone had to be a single parent? Really hard and sad and challenging things to talk about, but very, real questions to be open and honest about. And I think kind of getting back to this, a non-decision is a decision. And so, I've had some couples that year after year after year, they kind of come back and they're still debating and they're still thinking. And it's kind of like, well, this whole process of drawing it out and debating is kind of a decision not that you're not doing it. So at some point, like, it can be really stressful and emotional. And this is as a woman, right, who is thinking about pregnancy, not even having a vascular condition. Like, a lot of people are busting into your life and giving you advice and kind of inputting stress and anxiety on you. And so, you have to feel confident in your decision, but also by not making a decision, you've kind of made the decision. So I guess some questions that I would leave anyone with if they're thinking about what it means to be a family, what family planning would look like in your life, is like, what does it mean to be a parent? I think some people were put on this earth and part of their life experience was to be a parent, was to experience a pregnancy, was to have a family and be a mom or a dad. Like, their identity and their life will not be complete without an experience. And there are other people who are like, I have other things, I feel fulfilled in other ways, really doing that introspective work to figure out what you were meant to be on this world. Also, what are the risks you're willing to take? Again, a dissection or a terrible event could be 0 or it could be 1. It's going to happen or not, depending upon like how you view risks. And so how are you going to cope with that? What support systems? How are you going to manage all of that? And finally, do you have all the information that you need to make an informed decision? And if not, where do you go? How do you get that information? Clearly, the Marfan Foundation and all of its divisions are incredibly important pieces of where to get information. But also the flip side of that is just be careful. You're going to get a ton of different stories. And so as someone who likes to kind of workshop decisions, I am that person who likes to hear a lot of different opinions. At the end of the day, like, you have to be very comfortable and confident in the decision that you make. And so hearing other people's opinions, other people's stories can be helpful, but it can also muddy the situation for you or your partner. So really kind of go into it taking any advice or information, but making sure that you are making the best decision for you and your partner. So thank you. I really appreciate this time. And I see a few questions and chats. I would point out, I don't know if Melissa or sorry about that, or Andrea have been putting resources in the chat, but there are a lot of resources about family planning through the Marfan Foundation. So if you do want to read more or understand more, there are lots of webinars and YouTube videos and other things that you can certainly check out.
Thank you so much, Gretchen, for sharing all of this knowledge with everyone. This was really enjoyable. Just to listen to as someone that works at the foundation, I learned so much. We do have two questions that came up. The first question is, on average, what are the success/fail rates for pre-implantation gene therapy?
So I will try to answer that question. I think if I can understand it. So the success of the pre-implantation testing is virtually 100%. So I guess if the question is like, how many times do you think that people are getting implanted with an embryo that is really positive and they've missed it? I think that is incredibly rare to happen. So I think you can be very confident in that technology. Back in the day, they used to kind of require that women do a CVS or an amnio to follow up on that results. I don't think that's a requirement anymore. So I think the likelihood of actually getting negative embryos from PGT is very, very high. The success of getting pregnant using IVF, I think that probably, I don't know the rates in the general population, but I don't think those differ than the general rates of achieving a pregnancy through IVF. I think those are the two different ways to look at it and maybe interpret that question.
Your next question is, would most fertility clinics be able to test for TGFB3 for Loeys Dietz for IVF, or are there specialty clinics for that?
Yeah, so if there is a company or a lab that offers PGT, they again, you just need that report. I would say that they sometimes get some hesitancy if it's a variant of uncertain significance. But if it's clearly pathogenic or likely pathogenic, any lab should be able to do that. There's not like specialty IVF labs that only do connective tissue or only do this other thing. So it just is whether your local hometown IVF center will do the PGT technology. That's kind of the differentiation. You want to find someone that offers the PGT, and often a local place would also contract with other companies to actually do the testing. So there's a few different options there, but you don't need to find like a connective tissue PGT site.
Great. Okay, next question is, who are the various medical providers that we would anticipate being involved in pursuing IVF with PGT? High-risk OB, fertility specialists?
Yeah. So usually you're gonna get plugged into a high risk MFM. Again, this is assuming that the woman has the condition. So you're gonna usually get Well, I'm gonna caveat that. Usually you'll have an initial consultation with a high risk OBGYN or something called a maternal fetal medicine MFM specialist. For some individuals with Marfan, maybe some Loeys Dietz, they deem you to be very, very low risk, they might feel comfortable having you followed by a general OBGYN. At least that's the strategy here. Anyone with VEDS or higher risk Loeys Dietz syndrome is followed through the pregnancy by MFM here. So I think people can, differentiate there. So the PGT and the IVF part, you really want to probably start with reproductive endocrinology. And they'll usually have clinics where you meet with like psychology and all the different reproductive technology, physicians that you need. But I think that's usually, again, reproductive, I think endocrinology. Now I'm second guessing myself, but reproductive services will be able to help you through that.
Great. Okay, the next question states, as a female with VEDS, I've been told I'm unable to go on any kind of birth control and cannot have elective procedures. However, I was wondering if tubal ligation is actually an option as birth control, or is it unsafe?
Ooh, I might have to defer that to a physician. You know, so I've been practicing for about 20 years. And so I'm just thinking through like our general counseling for VEDS, and we don't 100% say that tubal ligation is off the table. So I'm just trying to think. That's a great question. I don't know that part of your system, is like considered a hollow organ that would be at risk of rupturing or tearing. I don't think it's 100% off the table, is what I'm saying, especially if you're weighing the risks of like a pregnancy, which puts you at higher risk versus, a lower risk for the tubal ligation. Um, that's a great question. Maybe that is a great question, Andrea or Alyssa, for Melissa Russo,
Yep,
to talk about, or to like maybe do a little connective tissue thing issues answer to
absolutely.
that.
The
And
next
what was the birth control question part of that? Sorry.
is that would the tubal ligation
Okay.
actually an option as birth control? Or would it seems like, or would the procedure be unsafe in general?
Yeah. I I don't know. I don't know that it would be off the table. So I think you should talk to your OBGYN about it for sure. But then maybe we can ask Melissa to do a little bit of homework into us that for us.
Absolutely. Okay, the next question is, can sperm or eggs be tested for one of these mutations, or is it only when there is an embryo?
It's only when there's an embryo.
Next up is, I have heard that the IVF and PGT technology is significantly lower in cost and much more advanced in some European countries like Spain and Germany. Have you heard anything similar? From what you know, how does the IVF and PGT technology in the US compare to the technology in other countries?
I don't know that that technology is that much different. I think there might be different um this kind of sounds very scientific, like solutions or like the things that they grow the embryos in, but I don't think the actual technologies differ that much. Just off the cuff, like I was looking into this for a patient from Greece, and we saw like multiple PGT IVF companies that were like in Athens and all over Greece. So I think it should be widely available in both countries. I don't know of any like very significant differences between the two. And I honestly don't know if someone from the US went to Europe, like the costs and all that. I don't know that information.
Looks like we have one more question here. What exactly causes the risk of dissection in pregnancy slash postpartum? Is it the hormones, the blood pressure, or something else? Are there some treatments that can reduce the risks during pregnancy?
Oh, those are really good questions. So it's kind of a little bit of a controversial question, I will be honest. And so I would guide you to some of Dr. Dietz's past research talks. So it primarily has been thought many years prior that it really was like fluid shifts that happen or pushing in the pregnancy that would cause dissections to tear or dissections to happen. But what we realized is that people weren't really dissecting like during the pushing when you think would be like the most stressful, the most isometric movement. That it really was kind of later in the third trimester or a few weeks after delivery. So that led to that whole question. What you were referring to in that question was like, could there be a hormone component? So, there were many studies done in the Dietz lab where they have mice that are genetically modified to have Marfan syndrome, and that had really poor outcomes after delivering their pups. And so the first experiment they did was they simply removed the pups so that the moms didn't breastfeed. And it went from like 10% survival to about 90% survival. So they thought that, gosh, there really is something in like hormone related breastfeeding, and that by simply removing the pups, they had significant survival of these mice. Caveat, mice, right? And so, one thing that could modify risk is that if we do think that hormones are related, and they've worked out the pathway that they think it might be related to oxytocin. Oxytocin is a hormone that's released to get women ready to deliver, but then in lactating individuals, oxytocin is a hormone that gets a big release whenever you breastfeed. And so they've done experiments with like oxytocin antagonists and other medications that block that hormone. And so the thought is that that is somehow hormonally related. Again, not fully studied in women. They're looking at, it's just really hard to get big numbers of women who have not breastfed versus breastfed, and then who've had dissections and not had dissections. Your N gets very small. But one consideration to reduce risk could be perhaps choosing not to breastfeed and reduce that hormone load that we think might be impacting the risk for dissection. Here at Hopkins, we take a very measured approach. And if you are breastfeeding, we might do imaging more frequently in that postpartum period in the first, 6 weeks, 6 months, a year out, or follow you a little bit more closely as you're breastfeeding. Versus if you choose not to, we might like space out that follow up a little bit more, as well as just really maintaining good blood pressure, etc. But it's a little controversial. There is research to support that it might be hormonally related, but kind of standard quo, thinking has been it really is that pushing and that pressure. So it's kind of both.
Great. It doesn't look like we have any other questions at this time. If anyone else has another question, please feel free to put it in the Q&A. Make sure Gretchen answers it before we wrap up. We'll just give it a few more minutes. Are you able to see the chat, Gretchen?
Yeah, thank you for your kind words. That's really sweet, people.
Wonderful. All right, well, I don't see any more questions. Thank you so much, Gretchen, for your time and for sharing all of this wonderful information with us. Oh, wait, we just had one more question come in.
Okay.
How important is it to be off beta blockers before getting pregnant?
So you should talk to your doctor, but actually, beta blockers are the preferred blood pressure measurement rather than angiotensin receptor blockers. So angiotensin receptor blockers are your like losartan, Cozar, irbesartan, Avapro. And it doesn't have to be a huge time frame, but with all these medications, any blood pressure medication, you don't want to like cold turkey stop them. And so you just want to like maybe 3-6 months before starting to pursue a pregnancy, have a plan for like a good, safe down titration. Oftentimes, if you're on an ARB, they will switch you to a beta blocker in pregnancy. There are some studies that show maybe there's some like smaller babies, but the ARBs impact the development of the baby as well as the fetal kidney development. And so that's why we want to get people off of that medication. And actually beta blocker is something that certain types of medications that you would want to be on in a pregnancy.
Great. All right, not seeing anything else come through. Does anyone have any additional questions? Last call. Okay, I don't see any more coming through. Everyone, this was recorded, so we will be sending it out. I'm not sure the way that they'll be doing it, but it will be available to view again. If you had any additional questions, you can always reach out to our Health and Resource Center. They are happy to answer any questions and point you in the right direction of different specialists that can be of assistance as well. But thank you so much, Gretchen. We appreciate it. Everyone enjoy the rest of conference. Thank you.
Thank you.
Bye-bye.